happy to have the guests here on our next panel, which are going to discuss a small county's approach to building crisis capacity. They're going to be discussing their Triage personnel grant, which is funded by SB 82 funding, which aims to reduce the time to crisis calls, to reduce the time that officers spend on 5150 evaluations, and also to decrease the use of hospital emergency rooms. So I'm going to do some introductions and then turn it over to the panelists. So we have John Lawless, who has been working in mental health since 2003 and was most recently appointed the Mental Health Director and Deputy Director of Health and Human Services in Calaveras County in September of 2014. Mr. Lawless has worked with MHSA programs in 2 different counties since 2004, and he has participated in the development of both children's and adult system of care programs. He has also actively participated in the implementation of SB 82 Triage grant implementation in Calaveras County. We have Jim Macedo, who's a 22-year veteran of the Calaveras County Sheriff's Office, which is located in San Andreas. He was the Operations Bureau Commander at the Sheriff's Office until the unexpected recent death of the Sheriff Gary Kuntz. He is currently the acting Sheriff of Calaveras County. He has held positions with oversight over several divisions, including patrol, investigations, budget and finance, jail, and strategic planning. We have Dean White with us this morning. He has worked 25 years for Dignity Health, which has 39 hospitals in Arizona, Nevada, and California, as a medical social worker. Mr. White was the Director of Case Management and Clinical Counseling at Mark Twain Medical Center until being promoted in March of 2015 to the Regional Director of Social Work for Central California and North State. Throughout the years, he has worked all areas of coverage in various hospitals and expanded the services in Calaveras County, rural health clinics to include a psychiatrist, psychologists, and LCSWs to reduce the gaps in service. We have Brenda Handley, who's joined Calaveras County Behavioral Health as the MHSOAC grant-funded Sheriff's Liaison in June of 2015. Mrs. Handley has worked extensively with the criminal justice population as an addictions counselor, including 7 years at Sierra Conservation Center and Baseline Fire Camp in Jamestown. She's also worked with dual diagnosis clients with the State of Nevada Mental Health Services and the 24-hour crisis program in Tuolumne County. And then lastly, we have Susan Sells. She is a senior administrative analyst for Calaveras County and has worked for the last 8 years with the MHSA services for both Calaveras and Tuolumne counties, behavioral health services. She's responsible for MHSA state component programs, including community engagement, proposal design and development, contract oversight, marketing, and public relations. So with that, I'm going to turn this over to our panel.
Thank you, Adrian. Thank you, everyone, for allowing us to come and present one small county's way of implementing the SB 82 grant. We have been doing this for, I guess, about a year now. We started in June of 2015, and so we're coming up on a year. Let me get my slides up here. And of course, what we're talking about is the SB 82 grant known as the Investment in Mental Health Wellness Act of 2013. And this legislation, not for all Californians, but for counties who competed for and received this grant, have an opportunity to take Mental Health Services Act funds and expand crisis services, and this has happened statewide. Again, not in every county, but in the counties that qualified for it. I want to give you a little bit of introduction by telling you something about Calaveras County so you have a perspective of how we've implemented this and possibly why it's worked in our county. First of all, we are a county of about almost 45,000 residents. This population number came from the 2010 census, so it has varied a little bit since then. We are in the Sierra foothills, which is mostly a mountainous region, and if you kind of want to picture where we are, we're almost directly east of Stockton, about 37 miles up in the foothills. We're one of the Highway 49 corridor counties. Also, we're about 100 or 1,000 square miles, which I don't know, when you compare it with some of the other countries in the world, we're a little bit larger than Micronesia, Luxembourg, Singapore, and we're just smaller than Rhode Island. I think one of the interesting things about that, though, is that 80% of our people are living in unincorporated areas. A lot of them in mountainous areas that don't have, well, after our Butte fire, which I'll talk about in a minute, a lot of them are lacking services, and we're having a really difficult time getting them down to services, which I think most small counties experience. And it's accessed primarily by two-lane roads. The only, I guess, option to that are the passing lanes that they finally put on some of these roads because of the frustration of people trying to go a little faster than some of the older folks or those that are a little bit slower wanted to go. Geography determines our service needs, the access to services, and the resources that are available, which, as all of you have experienced, are very limited. Some of the county challenges that we have faced recently is the recent Butte fire. Lake County has also experienced a tremendous impact by this fire. In fact, our staff and Lake County staff are meeting together to kind of talk about how best to approach outreach to the folks that are living in the outlying areas. We had over 1,000 homes and structures that were burned during this fire. It burned over 70,000 acres, and that has been devastating to our community. And even though it's not directly affected our SB 82 services, it's had an impact on all of our mental health and substance abuse services in that community. We have minimal public transportation, which I think is pretty common to most of the smaller rural counties, especially those on the 49 corridor. We have limited crisis response service for psychiatric emergencies. In fact, one of the things that we face is we have no inpatient psychiatric facilities or crisis stabilization beds in counties, so everything we do, we have to contract with others out of county in order to provide us with those services. The SB 82 funded triage services, I think one of the things that I want you to know about this is the importance of the partnership, and it's one of the reasons that this program has worked for us. From the very inception, we started working with the Sheriff's Department and our hospital in order to coordinate how we were going to set this up, how we're going to recruit, and how we're going to implement it. And I think that's really crucial when it comes to being successful. If any of you decide you want to try something similar to this, don't try doing it without those relationships in place, because we ran into problems along the way, and it was because of those relationships we were able to work through those. One of the things, actually a couple of them that we've done, is reduce response time to crisis calls. Our triage workers are able to handle some of those that are after hours or not. We are in the process of reducing the time that the deputies currently spend on 5150 evaluations and repeat crisis calls. We're trying to identify the folks that continually use those services, the frequent flyers, and we use our triage worker to go out and actually do interventions in the community with those folks, which has really proved to be beneficial and we're hoping has reduced these folks calling repeatedly to our emergency services. We also are trying to decrease the overall use of the hospital ER. And Dean will talk more about this because we have a very small ER and not a lot of capacity. We had some challenges in recruiting, which I think anybody's going to have if you decide to replicate this program. We really tried hard, and it took quite a while to recruit a person who was willing to move to a rural community and work non-traditional days and hours. We have her working well into the evening and on Saturdays, which not everyone wants to do. So that was one of the challenges that we had. Also someone who has a strong background in mental health, law enforcement, crisis management, and veterans issues, because we faced all of those with our triage worker. Someone who works well independently in a high-profile position. One of the things we really wanted to be careful of is finding someone who we could trust out in the community, someone who would be daily interacting with the sheriff's department, with a police department in Angels Camp, and also hospital personnel. And we felt like this was really important because they represent mental health to all of these different agencies. And if you don't have the right person in there, you have political problems right off the bat. So that's really an important consideration. Next is someone who was willing to go through the waiting process and go through the extensive examination that the Sheriff's Department put her through. And also someone who shows a strong commitment to go above and beyond. And I know this sounds like the ideal person, and in a lot of ways it has to be, because this is such a crucial program, and the impact that they have in the community, either positive or negative, can really impact the reputation we have. So we felt like this was really important. And it took us 1.5 years to find the right person. We implemented our program, as I said, in June of 2015, so we are not into it quite a year as yet. Some of the things that we went through, I've already mentioned a little bit about the partnership with law enforcement. I really can't stress that enough. I know a lot of counties struggle with their law enforcement in terms of relationships, and I think it's important to work that out before you ever try to implement something like this. Second is to establish and maintain confidence, buy-in, and the cooperation of law enforcement and the hospital. And thirdly, case managers need strong collaboration and coordination with the officers and dispatch, which we'll talk a little bit more about as we go forward here. We also decided the best way to implement this program was to actually place the person in law enforcement. Brenda has an office in the jail. She also has one with mental health, because we didn't want to lose her to the Sheriff's Department where we just have another deputy. We also wanted her to represent the best interest of our clients. So we coordinate with her and keep her tied to both, which I know is a challenge for her, but I think it's really been beneficial. And we also found that she needs to be available when the sheriffs are at the highest peak needs, which happens to be in our county weekends and evenings. Also, one of the things that we have found that's proving to be very successful is to be providing crisis intervention training to our deputies, all of our first responders, fire department personnel, the police department, probation, and we do that on a yearly basis. In fact, in 2010, we trained 120 folks in CIT in the community. And then in this year, we have 82 that have been trained in crisis de-escalation. And again, that kind of goes hand in hand with what we're doing in the program. So we feel that's very important and crucial to keep this program going. So some of the, nope, I guess that's it. Our sheriff is up. Jim Macedo.
Good morning, everyone. Can everybody hear me okay in the back? Okay. First off, my name is Jim Macedo. I'm a captain of the Sheriff's Office, as John mentioned. Can I get a show of hands? How many of you have behavioral health or mental health professionals that actually go out and respond with law enforcement to scenes? Thank you. Now, out of that same group, if you're from a rural county, which is defined by a population of 200,000 or less, can I see a show of hands of how many of you go out? Okay, great. Thank you. I'm going to jump into a quick joke here because I don't like to sit in front of boring speakers, and I don't like to sit in front of speakers that take up too much time. But I noticed a lot of you were playing with your iPhones as we set up. I'm going to pass a list around if I could get your codes before I go home. I appreciate it. And if you don't get that joke, see me during the break. If you're not watching enough news. So John mentioned Calaveras County. It is incredibly rural, but it is not without crime. It is not without mental health issues and problems. As mentioned, I've been there 22 years. I've seen the negative effects of folks that are mentally ill, that are being incarcerated and running through our criminal justice system, running through our hospital, and the impacts that's had on our entire kind of county structure, but also our healthcare system. So when this opportunity came up, I was actually excited. I know that's probably hard for some of you to believe that somebody in law enforcement would be excited about a mental health program, but I was, because I saw it as an opportunity to fix some long-standing problems that negatively affected not only me personally when I was on patrol, but also the entire sheriff's office. Law enforcement calls for service and response times, to kind of give you an idea of what our county is like. It is not uncommon. Our average response to a priority 1, a significant serious call for service, is 33 minutes in our county. Most cities and larger sheriff's offices, it runs anywhere from 2 to 11 minutes. So as you can see, it takes a long time for us to get to a call. In the case of a suicidal subject, person in crisis, or a 5150 call that's dangerous, when it takes you 33 minutes to get there, sometimes the event is over before you arrive, or sometimes that long delay has allowed that situation to unfortunately get worse. Even though we're a rural agency, we firmly believe in the community-oriented and problem-oriented policing concept. For those of you that are not familiar with that, we require our deputy sheriffs to not just respond to calls, whatever type of call that is, and just handle the call and leave. We encourage them to work on them, utilizing other non-traditional law enforcement services to solve whatever that problem is, whether it's a patient in a mental health crisis or a graffiti problem. We work with a variety of outside entities to try and problem solve that call for service or those repeated calls for service over a long period of time. It's very successful, but just as any program, you have to have the right staff and you have to have the right buy-in. Our calls for service in a given calendar year are about 44,000 per year. In 2015, we had 130 5150 calls in the county. In 2015, we had 154 attempted suicide calls, 18 confirmed suicides. Again, for reference, we're a population of about 45,000, but this may seem a little funny to you, but this isn't a joke. We have sections of our county where census workers will not go. It's for safety reasons, and John mentioned the fire, so our census isn't that accurate. Unfortunately, we have some people that just do not want any visits from the government, regardless of who it is. So our stats are accurate that are before you, but our population isn't, estimates according to the censuses aren't always exactly accurate. A lot of the cases, specifically the 5150s and the attempt suicides, involve repeat calls for service, where we're going back to the same location, dealing with the same person, and this is where Brenda comes in. What we wanted, because most of these calls are initially handled by a patrol officer, and that patrol officer responds, tries to address the issue, and if they do place a 5150 hold on somebody, it could be an hour and a half ride just to the hospital, and then you are in the ER room, and generally speaking, you are waiting while other patients are being cared for. Sometimes it takes us 4 hours to clear one of those calls. Well, that's a significant portion of that deputy sheriff's shift, and you'll see a map of the county here in a moment, but that will leave a large portion of our county without any law enforcement services for 4 hours. So that obviously negatively affects our ability to provide other law enforcement services. And I can tell you our patrol supervisors, our sergeants, it absolutely drives them nuts because you're leaving large chunks of the county without any sort of public protection. So when we were talking before we came here last week, those patrol deputies that respond to people in crisis, they're really there to kind of handle the problem initially, and they are assigned to work on it long term, but they really cannot treat the crisis case as though a detective would in a criminal case. And, you know, for lack of a better term, we kind of, you know, we rely upon Brenda as our crisis detective. She works with these folks long term. She finds out what the problems are in an interview process. But often the deputies that are truly working on the community-oriented policing process, they know, they develop a relationship with some of these folks over time, and they know that some of these events are triggered when the person drinks alcohol, when their brother shows up at home and agitates them, or that there's some other event. So they're able to relay that information to Brenda, and Brenda's able to work backwards, utilizing that information to try and reduce, you know, the cause and effects of the events that are leading to these crisis situations. Okay, so this is a map of the county, and all those white squiggly lines are roads. You'll see a series of circles. Hopefully you can all see that. There's a dark green circle. And I just want to talk about some of the impacts. I mentioned it takes us a long period of time to get to calls for service. And if we have a suicidal person who is armed with a weapon, and that call generates in that dark green circle, you know, we obviously don't turn our back. If we arrive and we do not find that subject, we do not just leave and move on to the next call. We have a public safety obligation to try and locate that person. Depending on how long it takes us to get there, you can see that search area expands, you know, extensively over a period of time. If we're unable to find that particular person, we can have our entire shift trying to set up a perimeter trying to find this person, again leaving the other type of, or the rest of the county open. One of the things that we try to utilize is to have Brenda working to prevent these types of incidents. She will get in there and help us determine if there's any weapons in the house. She generally will speak and will have a little bit of history on the person. And what we want to do is keep the issue contained in that small dark circle. Part of that is timing, and part of that is a little bit of luck, but it's also, you know, research and knowledge of the individual, and to get that back and forth communication between law enforcement and somebody who may know the individual in crisis. John talked about the position and the hours. I can't emphasize the flexibility with the position enough. Brenda will actually go into our jail and work with clients inside our jail, but as we mentioned, she does respond out to the field. So if a deputy is out and they're interviewing somebody and they believe that the person may present a danger to themselves or others, but there's that gray area there where there's been no admission to want to commit suicide, no family member heard anything, I can tell you from being there, it's very difficult to walk away from a home when you've responded there because you believe a person's suicidal, and when you get there they say all the right things, especially in a rural community, because you know if you walk away and that person hurts somebody, as a deputy sheriff, you're going to have some questions to answer. Somebody's going to want to know why you didn't provide services. So what Brenda's done, it's allowed us to kind of work those gray areas, those cases where it's not cut and dry that the person's 5150 or not, or suicidal or not, or having an issue. It allows us to bring somebody in who has additional training and experience that your regular 21-year-old patrol deputy who's never been married, never had a mentally ill relative, who's supposed to solve all these very adult clinical problems. Brenda also develops a relationship with some of these folks in the community, and she understands whether or not they need to be incarcerated. She can visit them while they're in the jail, and there's kind of a continuum of communication going on back and forth between patrol. I can tell you that patrol does not like to go to the same house over and over and over again. The deputies get cranky. They want to make a decision. And one of our large frustrations is deputies don't know what the end result is. They don't see the progress, or at least they didn't. Now that we're fortunate enough to have this position, Brenda attends our patrol briefings. She's able to communicate with staff as far as the progress that's being made. I'm not going to steal her thunder. She's going to talk about a couple of case case studies with some specific people where we've had some success. But in the past, you never knew what was going to happen with these folks. You never knew whether you were going to run into them because the situation has blown up, and you never understood who was working with them and exactly what was being done. And now we've been able to kind of bridge that communication gap. So that's been a benefit to us all. Brenda coordinates with our correctional officers as well. They certainly see things that are occurring inside the jail and are able to provide some useful information. She'll conduct follow-up with the correctional staff. As mentioned, she communicates, and she'll also plan. When some of these folks are being released, sometimes we know that there's triggers back in the home. We would like to try and get those triggers removed from the home before the person is released from jail, so they don't end up right back in jail. I mentioned problem solving. I can't emphasize that enough. She is a dedicated responder. We're not calling, while she's on duty, we're not calling the on-call worker. We've had some struggles with on-call workers, non-permanent employees, not fully understanding the dire situation. The deputy's on the phone trying to describe what's going on in a home, and you have somebody who's on a telephone trying to understand or picture what's going on, and you unfortunately lose a lot in between what's actually going on in a home and hearing about it on a phone call. And again, she's established a line of communication between law enforcement from the top of the sheriff's office to the bottom and behavioral health. She's able to coordinate with all entities involved, and she's able, again, to plan with patrol when also she knows somebody's going to be released from jail or released from a mental health holding facility. She's able to notify us in advance so we're not finding out via surprise of a 911 phone call. I think this is my last slide, and I want to conclude with this. There's a lot of catchphrases in law enforcement about smart policing. Some of it has to do with technology and crime mapping and use of technology. I want to tell you the reduction of calls for service in this program is in fact smart policing, and it's done without bells and whistles. It's done with human interaction, human contact, communication. People letting their hair down a little bit, not being so isolated in their respective professional silos, excuse me. And I believe this, we haven't analyzed it and we don't have the actual statistics we'd like to have at this point in time, but I can tell you that her efforts and the efforts of this grant are reducing calls for service for us. They're streamlining and speeding up our processes, and I do firmly believe that this is actually smart policing, and it is working. I'm not entirely familiar with what the rest of the state of California is doing. I do know a little bit about what San Joaquin County, our neighbors, are doing next door, but I can tell you this is a very beneficial program from a law enforcement standpoint, and if you are not interacting with law enforcement in the same measure that we are, I would strongly encourage you to take a look at it. So thank you very much for your time.
Good morning.
Good morning.
I'm Brenda Handley. My full title, if you want to get down to it, is, you ready for this? Calaveras County Behavioral Health Sheriff's Liaison Triage Case Manager 3. If you can say that 3 times fast in one breath, I'll give you a Hershey bar. So you may be thinking, okay, that's quite a title, but what exactly is it that you do? Well, think of me essentially as a mental health EMT. When I'm explaining what I do, like when I first started, and I was talking to the officers, the deputies, and the guys over in PD, well, what exactly do you do? Well, I'm a mental health EMT. And that kind of gave them a quick aha moment. So I go out into the field as a first responder, assess the situation, kind of decide if we need to hospitalize or can we do some kind of mental health first aid, and get that individual into appropriate services without having to go to the hospital and go that route. So that's how we're avoiding those trips to the ER where you end up taking someone in because they seem to meet criteria, and then that clinician shows up and is able to safety plan and the person actually goes home. I'm able to do that in the field, and that bring down the number of folks who have to go to the hospital. Like I said, we've got a very small ER. We're at I think 8 beds in our ER. Let's see here. All right, so reducing the need for officers to respond to multiple calls from folks not meeting 5150 criteria. So deputies find themselves sometimes going to multiple calls and ongoing calls from the same folks in crisis. And so when they get there, there's no laws that have been broken, so nobody needs to go to jail. The person may actually be quite psychotic, but not meeting 5150 criteria. And so without intervention, this individual is probably not going to stabilize on their own. A lot of times, these are folks who are not necessarily inclined to come into the clinic on their own and look for services. So whether I go out with law enforcement or they give me a referral and say, hey, this is what's happening with this individual, this is, their residence, this is where they live, and I can go out, I become that contact point for the individual out there in the community. So basically, you can think of me taking the clinic to the client, taking the clinic out into the field, and then getting them to come in for regular services. So sometimes just a little bit of case management can make a huge difference for folks out there. So reducing the need for officers to wait at the ER. Jim talked about how long an officer can be tied up. So if we go out and I assess the situation and, okay, yes, this individual really needs to go in on a 5150. I can write that 5150 and the officer will still transport, but once we get there, I stay there until the individual is medically cleared and the clinician that's going to do the full assessment and potentially seek hospitalization arrives to take over. So that's one way I'm able to free up our deputies. I am embedded with our law enforcement. Now, something that you need to keep in mind if you're going to implement something like this and choosing someone who's going to go out, being out with law enforcement, that means they have to worry about this civilian that's out there with them in the field. They need to trust me to be able to handle myself and not get in the way if things go sideways. So if an officer tells me, I need you to stay in the car, guess what I do? I stay in the car. I take direction very, very well. So a lot of times, they may go in first, kind of see what's going on, and they'll say, okay, Brenda, come on up. So I think that that's part of the reason why maybe I ended up being chosen for this position. My experience working with state prison, I understand the job that law enforcement and correctional officers do, and the characteristics of a lot of the folks they end up dealing with on a daily basis. I trust my officers to keep me safe while I'm doing the work I need to do out in the field, and then support me in getting folks de-escalated and stable enough to move into the next steps we need to take in this journey to wellness. I think of those deputies and those police officers very, very much as my partners. We are a team, and you have to think of, if you're going to go out and do this, you have to think of law enforcement as part of your team. It's not just, okay, here's behavioral health and here's the cops. You're this. It's got to be this. All right, so relationship with local veterans. We have about 5,400 veterans, about 12% of total population, and more than double the number of veterans living in California. We have a lot of veterans. I think part of it is because we have some of these very rural areas. Some of the folks that Jim talked about that don't want government up there are a lot of folks who have done their time in the military and they basically want to be left alone. They've seen some things. I'm not sure that we have any vets from World War II, but we do have vets from every conflict from Vietnam forward. Veterans in crisis and their families don't like to call law enforcement. it often just doesn't end real well. I think it's getting better as we're making changes in crisis intervention training for officers. Our vets up in Calaveras County do have kind of a loose, informal peer support system. And we have a couple of very dynamic local veterans who are working hard to improve that peer support and have helped push for a specialty veterans court in Calaveras. So we actually have a veterans court now that's getting off the ground. It's been useful for these folks to know that there is a liaison that can respond with law enforcement if the need arises. So I'm pretty excited about the interaction that I've had so far with the veterans in our county, and I see huge potential for working with those folks in the future. Okay. So short-term case management for folks who don't qualify for mental health services. Not everyone that I come across has Medi-Cal coverage, which, as many of you know, is a prerequisite for accessing services through county behavioral health. But I will help the client identify an in-network provider. I mean, I've actually, what's your insurance, gone online, pulled up their local providers. Not everybody is real savvy about that whole internet thing. And connect them with the appropriate resources. Give them a list of doctors and therapists that are in their network. So just knowing that they have a go-to resource person will relieve a lot of anxiety for clients. It's, I tell them, here's my card, you have a question, give me a call. We'll see if we can find an answer, rather than them stressing and then getting on the hamster wheel of worry, as I like to call it. Identifying ways to connect community members with local resources. One of the things that I do is compile local resources. I have binders this thick. I try to maintain a good supply of informational brochures for all of the other agencies that are in the county and the surrounding area. Anything that I think might be useful, that I can put information directly in the hands of the client, I like to have that right at my fingertips. And if I don't have it with me at the time, I will make another home visit and bring it to them. I don't expect them to come to me. Well, they can't come to me. My office is in the jail. So I go out to them. And I also make sure that they have my card. I hand my business cards out kind of like lollipops. And then I provide follow-up support. So someone goes to the hospital, they come back, yes, they stop in at behavioral health, and there is that follow-up. They may get a follow-up call from whoever the worker of the day is in the day or two after they come home. But I'm going to check in with them too. And so they're just kind of on my radar. I make sure they know who I am, and I make sure their family members know who I am. Because the beautiful thing is that sometimes we get to the point, and I'll talk about this at the end, where a family member, rather than calling the sheriff, will call me, and we avoid that law enforcement in the mix altogether. Let's see. Yeah, as far as the follow-up support. So I like to go out to the home if I can. A significant number of folks with mental illness and substance use issues end up in our jails and prisons. If you talk to most wardens across the country, they will tell you that they are by default mental health administrators as well as wardens. A lot of times, the inmates have both issues going on at the same time, mental health and substance use issues. So effective offender reentry entails looking at the strengths the offender has. What does he have going for him? And what are his barriers to success in going back out into the community? So one of the simplest things I can do to kind of up the ante for success is to get that inmate an appointment with our psychiatrist, or get an intake going within a day or two after they're released. So I can make that happen rather than them waiting till they get out. When they're about a month out, I can go ahead and make that phone call to behavioral health and get that set up for them. So I've been able to do a lot of reentry work with our inmates. At this point, I'm pretty much meeting with everybody within 30 to 45 days before they get out, the folks that are sentenced, and checking in with them. Hey, what do you know, or do you have any needs? Some folks, they're just going home. It's not a big deal, but a lot of them have got a variety of issues that can be a barrier to them having a successful reentry and hopefully not coming back. So let's see here. Addressing service gaps for crisis during evening and weekend hours, that's pretty much what I do. I have that non-traditional schedule. I work from noon to 9, Tuesday through Saturday. I think that that's probably pretty much a given for anybody doing this kind of triage work. You're not going to have that 8 to 5 gig. And that, I think, is one of the challenges to finding someone to fill the position. Talking to other folks who are trying to do this kind of thing, their clinicians they'll take the position, and the minute an 8 to 5 gig in the county opens up, they do this lateral. And you're right back to not having anybody out in the field. So during the day, we have a worker of the day that deals with any walk-in crisis, and after 5 p.m., regular hours are over. I don't know if y'all have noticed, but crisis doesn't keep bankers' hours. So hopefully this, those of you who are doing this, just find somebody that likes the strange hours. It works for me. So guys, don't change a thing. I like my schedule. I'll keep it. One of the cool things that has come out of implementing this position is the opportunity that I have to help law enforcement understand why some people behave the way they do, and then how to approach some of those behaviors so that you get what you need done without creating more problems along the way. I've done a lot of ride-alongs. You can have some pretty interesting conversations when you spend 4 hours in a car with a deputy. So again, the deputies are an integral part of what I consider to be the treatment team. I would not be able to do what I do without them. There's a lot of places that I simply would not be able to go if I did not have a deputy with me or law enforcement with me. And they're the ones that are out there on the street. They basically find these folks for me so that I can go out and do my intervention. They're my eyes and ears out there. So I get a lot of, even though I may not be out with them, I get a lot of feedback from them about what's going on in the community. So by going out, I can reduce some of those repeat crisis calls. If I can do a little bit of case management and get a person stabilized, get them connected with resources and services, you're not getting those 911 calls anymore. So I can do what an officer can't. And again, we're talking about a lot of these folks who are not going to come into the clinic necessarily. So taking the clinic to them is a huge boon. A couple of success stories. Had a 23-year-old female. She's got a long history of trauma, mental health problems, been conserved in the past, use of meth and marijuana, lots of meth. Every time she smokes meth, her psychosis just goes through the roof. So we would have a lot of extreme behavior that resulted in multiple psychiatric hospitalizations. She was evicted from her apartment, frequent law enforcement contact. So our work with her is a perfect example of law enforcement working with mental health. So with the support of dispatch and the deputies, I was able to keep track of this young lady, intervene when she was in mental health crisis, and then continue to build rapport with her. Even though she was still out there doing what she was doing, I had a relationship with her. And so we finally got her engaged in services. Going to groups in our integrated dual diagnosis treatment program, doing much better, getting periods of sobriety that she never had before. Now, it's not all roses and rainbows for this young lady. Even though she's on disability and has income, the lack of affordable housing, and I think some of you are probably going to be nodding your head, they do great, but not having housing contributes to their destabilization. They don't have a fixed address. So hopefully things will go a little bit more smoothly for her once that gets addressed. We're a rural county. There is not a lot of affordable housing, and especially since the Butte fire, so many people lost their homes. And so rentals for anybody are in short supply. And then, you come into, well, I need low-income housing. It's pretty much scarce as hen's teeth, as my grandfather used to say. But she has a therapist. Even if she does go a little sideways, she knows who to call. And now she has a relationship with us. So we're having a lot less interaction with her from the law enforcement side. A family call that I alluded to earlier had a young lady, well, she's not that young, a lady that was having some psychosis, turned out to be kind of medical in origin, but husband was calling about his wife's behavior. She eventually ended up on a 5150. I had actually gotten the referral. I went out to see the family, and she had been taken on a 5150 the night before. So I talked to the husband, kind of explained to him, the whole 5150 process, what to expect, gave him my card, and I said, if you guys need anything, give me a call. When she gets home, give me a call. So she comes home. She's still having some issues, and it escalates. So rather than calling 911, he picked up the phone and called me and said, hey, this is what's going on. I said, well, do you think she'll talk to me? Yeah, I think she'll talk to you. So I went out, and I was able to convince her to get in the car with her son and go back to the ER. No law enforcement had to be involved with that crisis situation, and it was handled. So that's a real clear example of how this type of position can reduce law enforcement's involvement in these kind of mental health crises when maybe they don't really need to be there. I have a vision for how I'd like to see this grow. I've only been at it since June, and I'm excited. But again, I think it all comes back to you have to have a good partnership with your law enforcement and with your hospital. That's what I've got. Dean, you're up next.
Thank you. My name's Dean White. I am very excited to be here. It's exciting times and changing times. So I am a regional director of social work. I work for Dignity Health Hospital System. We have 39 hospitals in 3 states. My region is Central California, which is Stockton, Bakersfield, and then I skip over Sacramento and I go up to Redding and Mount Shasta. So I have 9 hospitals, and my responsibility is we are in a new era of trying to standardize for our system care coordination, social workers, and that goes into the emergency room. We have found that, in fact, we recently hired a third-party agency to help us solve the crisis in the emergency room with behavioral health folks that are backed up in the emergency room. We are looking at standard approaches of trying to increase staffing, having hospital social workers have a stronger presence in the emergency room. And we have always recognized that there are a lot of walls up, and we're trying to break down the walls with relationships with community agencies. And we realize, obviously, that simply staffing additional hospital social workers on the weekends for coverage is just part of that and not looking externally. So this is a shining star for us. This is an opportunity. And again, we've always had relationships with home health cares and SNFs and discharge planning, and we have had a history of putting off the behavioral health clients because it was emergency room staff, quick process, lean and mean process for doing medical triage, and frequently behavioral health clients get the back seat for treatment when a emergency life-threatening crisis comes in, and it's just not the environment we want folks in there to be there too long. So our goal is to utilize this shining star and run with that and go from there. High-level overview. So my 9 hospitals, again, the first thing comes up, I always say, okay, I've had 8 years I worked at Mark Twain Medical Center, the only hospital in Calaveras County. And I always say, okay, well, I have to explain it's a critical access. Critical access means it's small. We have 25 beds. And in the emergency room, we have 8 beds. And so, but again, I always bring it back to the fact that now with my position as a regional director, I'm working with the hospitals that are the small, the medium, and the large. So my mission is to find the relevance to use this as an example, see what we have in other markets in the emergency room with the crisis triage and the interactions, because everyone has different systems, different experiences, different resistance with different agencies. And my goal is trying to break down those walls, those barriers, and find how this program can be implemented or elements of it so that we fine-tune and have a little more standardization as to how folks are treated in the emergency room. So again, our hospital is very small. When a person comes in, when they're brought in by the Sheriff's Department on 5150 hold, it is not uncommon for folks to be there anywhere from this minimum of 4 hours to 3 days. I mean, they have to do the medical clearance. So we do, and again, if you visualize the person coming in with the sheriff in handcuffs and then sheriffs are tied up, everyone's tied up, it's not a conducive environment of folks de-escalating. When they are medically cleared, and again, that takes as long as it takes to get medical clearance, and then we wait for county mental health to come over and do the assessment, and then you're hoping they're not a 5150, because if they're not, then they can be set up for outpatient services and they can move out of the emergency room. If not, then they're placed on a 5150, as it should be, and we seek the appropriate inpatient setting. But as we already stated, we don't have an inpatient bed in our county, and most of my 9 hospitals, that is the case. So again, I'm always trying to compound this as to emergency rooms across the system are seeing the same difficulties with finding placement when there is a 5150 and the long hold time in the emergency room. That being said, again, in my hospital, luckily we have a county mental health that is very good at working with us and doing due diligence and trying to be timely with finding a bed. There's a couple of outlier cases where we've had folks stay longer than 3 days in the emergency room on a hold. Now, at other hospitals, I won't go into it, but again, I've heard war stories of people being in there for a week or 2 in the emergency room on a 5150, stacking a hold, which we're not supposed to do, but you get in a bind. So again, trying to get through all that. We've already expressed limited access, psych access, limited wraparound services. It's imperative that having crisis triage, whatever the format, out in the field is so essential to have folks not continue to escalate. And my point with the emergency room is that often they continue to escalate. And typically, we're not quick on getting behavioral health psych meds on board because we're trying to do all the labs and the tests and everything else before we get any medicine in them. Shortage behavioral health providers, primary care MDs. We have a lot of, so my hospital, again, I explained the critical access. We have a lot of regional or county rural health clinics. And so we have 5 rural health clinics in different cities within Calaveras County. Those rural health clinics, what we've done to fill some of the gaps is instead of having PCP or primary care doctors, we have a lot of nurse practitioners, physician advisors that are overseen by the physicians, and that's where we've beefed up our services And, but the same as before with managing the clients after that, we will set them up with those rural health clinic providers. I've already explained, ED's our emergency department. I always go back and forth between the emergency room and emergency department. It is with the trauma and the injuries and the motor vehicle accidents and the head injuries and everything that all of us have seen in the emergency room. Again, if there's any volume of patients that are in crisis out in the field, anyone that we can avoid not coming unnecessarily to the emergency room is going to help in the long run for everyone. And that's the point of this Shining Star opportunity. And as stated, we need diversion options to avoid the emergency room and the jail, because another term that's often used is the emergency room, the jail, end up being the dumping ground. And we don't need that. We need appropriate early intervention, breaking down the silos and the walls, and having community relationships so that we can intervene at an earlier point. So we talk about building relationships. Here's some simple stuff. You know, so often I think what I do, a lot of what I do, I think is common sense, and yet it's just bringing people together, you know, building those relationships. So in our emergency room, you know, there had always been them versus them and us. So it's the staff, the hospital staff in the emergency room that are doing all that they can, the physician, the nursing, you know, quickly triage, quickly treat, appropriately treat, admit if you need to, the whole process. We have the medical process down. But what we didn't have is we create often a resistance with ourselves and county mental health, because county mental health would come in, they only come in after we've got an assessment to be done. Okay, they're close to being medically cleared, or they are medically clear. Now you do your thing. We're done, you do your thing. And so it was us and them. And there'd be a couple of difficult cases, and there's finger pointing, you know, which is often, okay, what's taking so long? Why is it so difficult finding a placement? You know, they've been here for 2-3 days. So there's a lot of friction, a lot of anger that builds over time. And that's where we talk about building these relationships and how crucial it is to having ongoing dialogue with the agencies instead of pointing the fingers or finding that bridge. And so the bridge we found was, I'm a hands-on guy. And we set up a meeting, and of course, you know, one meeting leads to another, and if you step away, then you 2 steps forward, 1 step back. But what happened was, and it was a simple solution, is we thought there was going to be all kinds of issues. We had a meeting with county mental health and our emergency room staff, and I was kind of the mediator. And mental health staff that come in feel it's a foreign environment. They don't feel part of the team. They don't feel they're welcome there. They feel there's, you know, just things could be better. And emergency room staff feel, well, they didn't see it that way. You know, it's kind of a hospital setting. It's our facility, and they're guests, but we're not really treating them as guests. So some of the core essential things that are very simplistic is what we resolved was county mental health says we don't even have a place to sit. We don't have a phone. We don't have a computer. We don't have a printer. We come in, we do the assessment, but if it's going to take a couple of days or however long it's going to take, they're going to go back to their office and they're going to work on other cases. So that builds that belief that our case is not getting the priority that it deserves. So if we had a station in the emergency room that they could have the seat, have the computer, do their work, do the referrals, and they didn't feel they were in the way, then they would be, in essence, part of the team. And that's what we've built upon, is having part of that team where they have those essential elements that, and then we have regular meetings to follow up to make sure that when there is that frictional case, that we get that resolved so that there's better team working relationship. We talk about co-developed protocols, delineation of providers' roles. engaging law enforcement, mental health, roles. Something as simple as another element that was controversial was if someone's in our emergency room on a 5150 hold and we need a sitter, who does the sitting? And so emergency or the hospital has always taken the stance of saying they're medically cleared, you put them on a 5150 hold, so they're your patient. So we insisted on having their staff sit with the patient. Well, again, we're short services and there needs to be collaboration, and so we have now found a working relationship in sharing that responsibility where we have trained our staff to have additional sitters when they're not scheduled and all that, with additional training. And so that County Mental Health will split this shared 5150 sitting, and we will too, when you need that, have that requirement, because most emergency rooms do not have a secure room or a secure environment of that sort. Data collection, we talked briefly. This is exciting, and I'm already, I'm starting to look at the numbers, and, I try not to, I'm an optimistic guy. And so the numbers in our emergency room, it's not uncommon for us to see 2 or 3 clients in a given day that are on a hold or pending evaluation for the hold. And so again, when you have 8 emergency rooms and you've got just 2 clients that are on a hold, that impacts you significantly. And so again, if I were looking at the medium to larger hospitals, it is magnified. And so we need to collect with the interventions that are being done, and we have just started doing that as to how many cases on a weekly or monthly basis are being diverted and avoiding the emergency room. Because then again, you can really run with that data as to showing the relevance of the importance of diversion, crisis triage, helping out with that. And so far, what we've seen, easily, I would say 20%, so if I'm saying 2 or 3 a day, I'm saying even if I just have 1 a day less person in the ED on a hold is significant. We're doing that, expand outpatient. So with expanding outpatient resources, I got to tell you real quick, we have also, I was fortunate a few years ago to look into also counseling services that were and were not available in Calaveras County. So Calaveras County, we've got County Mental Health, and again, they're doing all that, and we've got the psychiatrist and counseling services and chemical dependency services. That's fine. With my background and where I work, the hospital, but we've got these 5 rural health clinics. So I found out years ago that, we're kind of unique, even though I'm part of this bigger Dignity Health system. With the rural health clinic, you can, if you have the right staff, the LCSW psychologist or psychiatrist, you can bill for those services. So 8, 9 years ago, I started providing psychotherapy myself in the clinics, started the program. Since then, it's grown. We now have 2 full-time LCSWs and a psychiatrist providing services at our rural health clinics. And so we have established that in our healthcare system that we have those services, and that has grown. And we see the population that has the insurance that, you wouldn't go to county mental health like Medicare and the private insurances, but we also see the Medi-Cals. And again, over the years, we've been building a relationship to find where's the best environment for our clients, whether that's at county mental health or our rural health clinics. Because again, with our nurse practitioners and our physician advisors who are often managing the medical care, they're kind of linked with our system, and they are or aren't being seen by our counselors or county mental health, not simultaneously. But we're trying to find, and we've been finding, that relationship so the high and moderate risk are seen by county mental health, and the medium to low risk are seen by us, and having that working relationship so that we can build and fill those gaps and not just have the medical system and the mental health system. So we're looking in other ways to expand that. Oh, so summarize. So, this is just the final slide. Reduces overall cost of care, providing crisis at the least restrictive manner. Obviously reduced ED, emergency department utilization, improved, reduced wait time. Obviously improves patient satisfaction and shifting to the appropriate level of care. Improved outcomes, reduces the acute crisis, and that's that. Okay, thank you.
So I'm going to be very quick. As the MHSA analyst for Calaveras County, I helped and partnered with the Sheriff's Department, the hospital, and of course our administrative staff in developing this grant for 3 years, and we submitted it November of 2013. And as you know, it took 1.5 years to find someone as wonderful as Brenda Handley. So what I am here to share is a recommendation we've made just recently to MHSOAC, that when there is a next round of 3-year funding, that small counties, which comprise 30 out of the 58 counties in California, that we receive baseline funding instead of having to compete with the larger counties for ongoing funding, which would be so important because this fund, because we have small budgets and inadequate resources in small counties, these funds would be absolutely critical to keeping this position funded, because we are only getting a small percentage of Medi-Cal reimbursement for this position. So it's impossible to sustain it without ongoing SB 82 support. So we're proposing, let's see, that instead of competing, again, that, let's see. An example, when we're at the triage meetings, we realize, as it should be, the larger counties who have received this grant have up to 25 people on their team. We only require 1, which would be very much the same for the other small counties in California. So we are requesting $120,000 of baseline funding. So I don't know if we have any legislators in the crowd here, but certainly MHSOAC, that, let's see, I'm trying to go quickly here for you, that it would only represent, and this to me is very important, 10% of the 32 million SB 82 triage funds allocated to California each year. So 10% would support 52% of the residents in California. So it's a real effective way of getting important resources to small counties, leaving 90% for larger counties, and they could either be funded based on population and need, or it could be a competitive piece. But this is our special request. I think it would make all the difference because we are seeing such amazing success in a very short time. It's going to be a critical service we want to provide ongoing, and absolutely non-competitive. It'd be so wonderful not to have to compete with the larger counties. So the last piece is that if Calaveras County, along with 29 small counties, can provide these triage services that reduce the costs associated with the inpatient and emergency room care and better meet the needs of individuals with mental health conditions in the least restrictive manner possible across California, we're hoping that this request is considered. That's it.
So I think we have time for questions or comments for the panel.
How long is the grant and how are you going to sustain it?
That's what we're hoping. We'll get some help from MHSOAC. We have some different options for sustaining it, and that's one of the things we hope we can do, is not lose it at the end of it's 3 years, 3-year grant. And we have got a little bit of an extension on it since we took a year and a half to find the right person to do it. We're looking at some different options. I really hate to get into those because we haven't talked to the people that might help us with that.
Yeah.
Right. But we do have some thoughts on that.
Brenda, what does a program look like when you're sick or on vacation?
I am a one-man show as far as, rolling out with the deputies. I would have to say that the best that I would be able to do is let clinicians know, because sometimes I'm working with their folks, that I'm not going to be around. I certainly have to let dispatch and deputies know that I'm not available when those things, like today, letting them know, hey, I'm going to be in Sacramento today, so,
They then go back to the way they did things.
don't really have much of a choice, like I said, because I'm the only one in the county, and I work 40 hours. Yeah, that's one of the things that's kind of frustrating, is that leaves a whole lot of hours in the week where there's not someone who can respond. But then that's where, again, my officers are my eyes and ears out there. So when they run across a situation, they will let me know, hey, I encountered this individual, this is what was going on, and I can follow up. So if all else fails, at least I can follow up, go out there, do whatever needs to be done to stabilize that situation, or keep it stable if it's already kind of settled down. So.
Just another quick thought on that is, I think with the improved relationships with the Sheriff's Department, that's also helped in them having a little more confidence in daytime staff, that if they need help because of the kind of the road that Brenda has paved, we do have a little better relationship with the deputies too. And so when she's not here, it's not ideal, but I think we do have a better relationship.
Terry?
This question's for John. John, are you looking into the peer respite aspect of SB 82, or do you have any thoughts about that?
We haven't gotten that far yet, Terry. Certainly that is something that we need to consider, though, going forward. We are looking at it with the veterans. We're trying to find some peer advocates with the veterans that we're also trying to work with the Sheriff's Department, so that when they respond to a veteran, we might have a peer go out with them. We haven't got there yet, but it is something we're working on.
So you're going to compete for those funds?
Pardon me?
You're going to compete for those funds, the peer respite aspect?
I'm not sure we've thought that through yet. We're looking more at how can we implement this aspect of our treatment. We've got a couple other grants that we're working off of right now, and one that we've just applied for that will help us with that as well.
Okay, thank you.
Hi, I'm from Santa Cruz. And we're working on our 4th liaison at this point. We've had a liaison program for 3 years. And now that we are fully in 3 jurisdictions, in a patrol car, 40 hours a week, and so on, we're facing the next level. And so this question is really for anyone in the room who has law enforcement liaisons. We're now being asked to have our liaisons trained in hostage negotiation training, kind of really stepping up the level of law enforcement involvement. So, we're kind of at a critical point as we expand our liaisons into how much is our role and how much is law enforcement. So just an observation.
Hi. I worked across and lived across the river for many years, as you know, John. So I'm really familiar with the area and just applaud what you're doing. Congratulations on your new jail. It looks great. I have a couple of questions. One is, for the EDs, can you help the other Dignity hospitals with the message that we need private, secure spaces to do our work? Because we have dedicated staff to EDs, and my staff had to go out to the car to make phone calls, and the nursing staff all thought they left. So if Dignity and Tenet and the other hospitals can understand that we're trying to be good partners, but we do need some space to be able to do that work, Dean, go for it. Just work with your corporate offices to say, hey, we're trying to do this well and help you, but we've had several conversations. We have quarterly meetings with our EDs. We have both Tenet and Dignity hospitals in San Luis Obispo, and have been educated on the culture of EDs several times, and would like to really bridge that gap well, but it takes both. The other thing is reminding the hospital administration that they can also contract with psychiatrists for ED consultation. Not everything has to be run through county mental health departments. So a little bit more collaboration, cooperation from the hospital corporations would really help us do our job, and I think would help us achieve some of the goals that you're achieving. The other question I had was more for Brenda, is how do you, or maybe John, how do you deal with PHI issues? You say that you do a lot of communication with your law enforcement partners. We also like to do that, but how do you manage that? Do you get releases from everybody, or how do you manage? Thanks.
I get that question a lot. In the midst of course, in the midst of crisis, the officer is there with me. He's part of what's going on. After the fact, you walk a really fine line. And so I probably am more, I don't want to say this, it's like very, very at the forefront of my mind, but my officers are really good about, they don't ask me questions that they know I'm not going to answer, but they see the results out in the field, because they run into the folks, a lot of our cops, they have like a beat. So they know who lives in their area. So I think that sometimes there's a little bit of a more personal relationship between the officers and the folks that I tend to see. So they'll talk, if the officer's out in the community and it's like, hey, how you doing? What that client tells that officer, that's his business. So, but I have to keep it right here all the time.
And after the crisis is over, Ann, we do work with the either an inmate or if it's someone in the community to get releases of information so that we can talk to those who we need to talk to.
Just had a quick question. Back to the conversation around the sitters. I'm wondering if you've ever had the discussion around hiring peer support providers to provide that service. That seems like a wonderful opportunity. It's such an incredibly frightening place to be for the individuals receiving services that I'm wondering if they currently perhaps maybe even are peer support providers.
Our system, we talk about our system, and it's a wonderful system, and we're trying to, it's a continued growth with the culture in the emergency room. Even though we have a system of 39 hospitals, they have in many ways operated independently because of the local issues. That's a wonderful suggestion, and we've just started that thought process, at least with Mark Twain, because we need to look at those missing resources and the strength that would add. We also find that in each hospital, we do the education and we do the training, and like was mentioned in the prior discussion, that helps for a little bit, but then people tend to go to old habits. We need boots on the ground. We need that person. Each initiative needs someone in that environment to bring the players together and to look outside of the traditional boxes and have ownership. And that's what we're working on, is trying to have in each location, whether it be a social worker or the emergency room manager, whoever's going to own that. So we have a liaison to look at those opportunities.
So I think we're about out of time, but I really want to thank our panelists for the time today and the presentation. And